I'm really pleased to introduce our first feature speaker, Catherine Harper, who's the Director of Crondar Consulting. Catherine is a public health epidemiologist with extensive experience both internationally and nationally in government, academia and consulting. Catherine is going to share some valuable insights into the cascade of evaluation and monitoring measures that connect through from the Victorian Public Health and Wellbeing Plan all the way through to cancer services, the VICS and beyond. Having worked with Catherine before, I know we can expect some really clear and actionable information for evaluating impact. Thank you, Catherine.
And thank you, Anne. I hope you can all hear me. Just let me know if you can't. So thank you for the opportunity to talk today and to have this discussion around how you can demonstrate the impact of the VICS. So I'm going to address these 5 points here. But as Anne said, in addition to the first point, which is what are the key concepts of monitoring and evaluation of impact, there are some overarching high-level frameworks to use in addressing how to measure the impact of VICS. So if we think about the 3 key concepts of monitoring and evaluation, I'm going to talk about definitions. So what is monitoring? What is evaluation? How do they link? The outcomes approach and what that means, the what, the how, the who, the why. And then another core concept for thinking about demonstrating impact is what is your accountability for change? And by addressing and understanding your accountability for change, you will then generate actionable insights from your evaluation and monitoring in order to lead to better decision making and improvement. So monitoring and evaluation are not the same thing, although they are often confused and lumped together as if it is one thing. Monitoring is a subset of evaluation. Evaluation is a large, planned, periodic, point in time, purposeful activity that looks at information right across the results train, from inputs, activities, outputs, impacts, outcomes, all of it together, and analyzes it and systematically reviews it all. It generally includes numbers and words, qualitative and quantitative data. Monitoring is a subset. Monitoring, again, is systematic. It's a systematic process of collecting and analyzing and using information through a project, a program, a strategy to track progress and impact using very specific defined indicators. So it is a quantitative process regularly done, whereas, say, an evaluation could occur at a formative stage at the beginning, halfway through, and then as a summative stage at the end. It is not a continuous process. Monitoring is a continuous process and is used for interim decision making. So if we're talking about measuring the impact of VICS, one of the key questions is, what is the time frame and the scope of the measuring of your impact? The other core concept that I just wanted to touch base on, and I'm sure this is not a new concept for any of you, but let's think about what is an outcomes approach. So when we say we're measuring impact, we're measuring effect, we're measuring outcome. So taking an outcomes approach is about focusing on and measuring what matters. So we know where we want to go, the light on the hill. We set ourselves on a path and we follow that path with decision making along the way through a monitoring process. And the evaluation talks about, did we get to the light on the hill? So an outcomes approach requires that you be really clear about and focus on what you want to achieve. And that can be in the short term, the medium term, or the long term. But exactly what do you want to achieve? It requires you to determine who or the population group, which is at the center? And speaking in a health context, is it about the population broadly? Or is that about patient change, individual patient change, watching your corridors of care and your patient outcomes as an individual? So who is at the center in your monitoring and evaluation? And then you measure progress along the way using impact measures. And they are again providing useful information, actionable insights. There's a whole separate part to all of this, which is not the outcomes approach, but it's how to achieve the change. And that's about your process measures, your outputs, that sort of thing. And that's captured in your strategic plans, your operational plans, and the like. That's the how. Whereas the outcomes approach is the what. What do you want to achieve? And then another question is, why did the change occur? And that's another core question for measuring impact. And that question of why the change occurred is captured in intermediate outcomes using program logic. So we know from an evidence base, if this happens, then it's expected that this happens, expected that that happens. So using that program logic, you can consider how that change could have occurred and think about, are you talking about change for the entirety of the population or person-based change, which person-based can aggregate up into the population of patients, but it's a different cohort. So that's a very quick summary of taking an outcomes approach, which is all part of measuring impact. The other core concept for monitoring and evaluation is this concept called measuring the right impacts or assessment and accountability for change. I break change into three categories. There are changes for which you control it. For example, different interventions of multidisciplinary teams. Do you have the staff available? What do those teams do? There's a direct link between the program and the change. So they're under the control, and they're under the control of a project, or more broadly under the control of an X. Then there are changes that you can influence. You don't control them, but you have influence. And that influence can range from very strong influence to much more subtle influence, and uses a vast variety of techniques, from advocacy and other ways you can influence with your partners and within your organizations. So that your accountability for change on those things you influence is lower than your accountability for change where you can control it. And then there are other changes that occur which are contextual. You don't influence them, but they're really important as direction setting, as goal setting, and allow you to see the broader context within which you work. So there are three types of accountabilities for change, and knowing what you control, influence, and what is contextual is all part of deciding how you're going to measure impact, by understanding what are you accountable to change. So if we look at the changes for which you can control, they are most useful for decision making because you're right there, you can control it. But if you only look at the changes you control, you miss the bigger picture. You miss all that context that's happening around you and all the things you influence. So if we move to measures to achieving change through things you influence, that shows the influence of your partnering, your advocacy, and other collaborations and other processes, but it too misses the bigger picture. Whereas contextual changes, measures of contextual changes, provide that bigger picture and show collective impact. So again, thinking about how you're going to demonstrate impact, think about different changes that you are seeking in an outcomes approach within the control domain, the influence domain, and the contextual domain. So just as examples of the sort of measures that you would have under control, you have a fair degree of control over some components of the patient experience. You have a fair degree of control over some of the components of optimal care adherence. So they're control. If you look at influence, you influence survival rates for cancer. You influence the death rates for cancer, but you don't control them. There are many other factors at play there that influence cancer death rates and survival rates. And then looking at contextual measures, cancer incidence is a very, very important piece of information for the planning of your services and for goal setting and the like. But it is a contextual measure. Other way to look at that is smoking rates. Smoking as a risk factor for cancer is very strong, but you don't influence smoking rates in your population. But it's important you know what it is so that you can measure and consider future practices. So that's the third part of the core concepts that I wanted to just touch base on, lightly touch. So I'm going to talk about the Victorian cancer-related monitoring frameworks that we have and look at each of those in terms of what they contain, how they're reported, and the implications for the VICs. So I'm going to start at the very pointy end, at the top of our triangle, which is the Victorian Public Health and Wellbeing Outcomes Framework, which is about the entirety that impacts public health and wellbeing for the entire population of Victoria. Again, that's a big light on the hill, some distance apart, some distance away. And then we have the Victorian Cancer Monitoring and Evaluation Framework, which is a population-based framework for the state of Victoria. Then we have the VICS Monitoring and Evaluation Framework, which is much closer to home here and articulates through to those other frameworks. And then we have the Optimal Care Pathway Tumour Summits and the report we heard discussed earlier. So they all articulate through, and I hope to show you some of the lines of context that they lead together. So the Victorian Public Health and Wellbeing Outcomes Framework was published in 2016. I'm not sure how many of you are familiar with that, but that is this very large overarching framework. It has been reviewed in 2014. So it covers 5 domains, which, as you can see on the screen there, are very broad. It captures outcomes, indicators, there are targets, and there are measures. That framework, parts of it are reported annually. It has never all been reported on, and there are some measures that are not developed. So it hasn't been implemented completely as planned. However, importantly, it informs the 4-year Victorian Public Health and Wellbeing plans, which mostly focus on risk factors and focus then on the core risk factors for cancer. Considering the actual measures in the Victorian Public Health and Wellbeing Outcomes Framework, there are cancer-relevant measures of prevalence rates of the cancer risk factors as listed there. There are the proportion of adults, adolescents and children with very good and self-reported health. These are very broad measures. There's HPV 3-dose vaccination coverage, which is a tighter measure in relation to cancer. And there's premature death rate due to cancer. So again, thinking about things that are contextual and things you influence. There are some of those there, but most measures from a VICS perspective are contextual. But the measures provide line of sight to the goals and achievements at a whole of Victorian level. And that's where the Victorian Public Health and Wellbeing Outcomes Framework sits. The next framework I'm just going to touch on is the Victorian Cancer Monitoring and Evaluation Framework. So if we think about that in a hierarchical sense, it grabs some of the measures from the Victorian Public Health and Wellbeing Outcomes Framework and expands very broadly in the focus of cancer. So there are nearly 100 measures across 17 result areas and 7 outcomes. It is a very broad framework. It is a monitoring framework only because it is based upon quantitative measures reported moderately regularly. As you can see, it's 2018, 2020, 2023. And it looks at a population level, at an outcomes level. The data for the Victorian Cancer Monitoring and Evaluation Framework, which really should be called the Victorian Cancer Monitoring Framework, is reported by ICS in a geographic sense across the state, and it's reported for the state by sex, male and female, by low socioeconomic to high socioeconomic quintiles across the state, for remoteness and specifically for Aboriginal Victorians. So there are some measure of more vulnerable populations included in the reporting of this framework, and also some measures that relate to geographic difference. It doesn't go to explaining why those differences occur because it is a monitoring framework. It states where those differences are. So the Victorian Cancer Monitoring and Evaluation Framework uses many databases, which I'm sure many of you are very familiar with. And importantly, it uses some linked databases, which again is a very important way that we can aggregate information around individual patients and the impact of individual services through a program logic approach. However, what is widely discussed and acknowledged is there's actually limited access to primary healthcare data. And within that framework, there's very little primary healthcare data. Nationally, this is recognised, and through the Australian Institute of Health and Welfare, there are a number of projects being undertaken to try and develop linked data through from the hospital systems, through the primary care systems, through the registry systems and the like. One project is the National Primary and Acute Care Data Linkage Project, which is working on linking GP data through to incidence, hospital data and incidence data. But that's a major gap in this framework and in many other frameworks. So if we think broadly about within the Cancer Monitoring and Evaluation Framework, what are the hospital related measures? So these are measures that the hospitals control and measures that the hospitals can influence. And I haven't separated them in this, but there are many measures within the Cancer Monitoring and Evaluation Framework that show the impact of hospital work or the influence of hospital work. So there are death rates, there's increased survivorship quality of life, there's equitably reduced cancer deaths. So the inequities are looked at in premature deaths, again by ICS, SES, and for Aboriginal Victorians. So trying to see the inequity across the state of Victoria in cancer deaths. And then a domain area is increased adherence to the optimal care pathways. There are many measures in the framework that report against for increased adherence to optimal care pathways. Those relate to, they start at days from diagnosis to primary curative treatment, go all the way through to specialist palliative care, aggressive interventions within 30 days prior to death, and proportion of deaths due to cancer that occur in hospitals. So there are a large number of measures in the cancer monitoring and evaluation framework that would inform demonstrating impact in the hospital of cancer. Of note, there are a number of measures within there that are not developed. The data is not available. So there is a distance to go in order to report against this framework. However, it is in train, and there are plans for the generation of much of that data in subsequent years. The other measures that we've got is survival rates, 1 and 5 year survival rates for all cancers and specific cancers, and then survival rates, whether they're diagnosed at stages 1 and 2 or stages 3 and 4. So there's a lot of definition within that work there. Improving quality of life with a health-related quality of life following primary treatment score, which is available then for ICS. Another domain is improving patient experience of healthcare, and there are a number of measures in the framework that relate to the Victorian Healthcare Experience Survey, as well as the Cancer Experience Survey. And then there is a section on innovations and improved evidence of best practice. And again, they are very relevant to the work of clinical trials within hospitals. So there's a lot within the cancer monitoring and evaluation framework that can be used to assess or consider the impact of the VIX and demonstrate that impact. So the data is published publicly for the ICS geographic areas and includes public and private hospitals where data is available. NEMICS and other ICS are provided with unpublished data for many of the indicators that can be assessed at that level. For each NEMICS health service, each of the 4 in your specific case, some measures are provided by locality of residence and others by the treating hospital, because you can imagine the data can be cut in both ways and tells you different pieces of information. It does not provide insight into why there is variation between population groups and the geographies that we are provided data with. It looks at the indicators one after the other and does not, by design, assess a patient corridor of care or a patient pathway and look at why there is variation in these groups. That would be the subject of an evaluation, not the subject of a monitoring framework. So it's important to know what it is you're seeking. Are you seeking to monitor, or are you seeking to evaluate when you think about demonstrating impact of the VIX? The next framework I'm going to talk about is the VIX monitoring and evaluation framework, which you may not have heard of, and Anne has told me that. It was drafted in 2022 to provide a consistent statewide VIX approach. However, it was never finalised. It is under review and has never been reported against. But the framework in its draft form provides lots of very useful information for you to consider if you're looking at demonstrating the impact of VIX. This is not about demonstrating the impact of an individual project like we have seen very expertly done in the 3 projects we've seen earlier in today's session. This is about thinking at the level of the ICS or the VIX. So the VIX monitoring and evaluation framework is a merged monitoring and evaluation framework with extensive data collection requirements. So it's a very resource intensive framework to implement. It includes output and impact measures. It covers appropriateness, effectiveness, and efficiency. So it is very broad in its reach, and not unrelated to that, it requires extensive data collection and is resource intensive to implement. So it's not something that would be done regularly, annually or the like. It is a very large project to implement. It does provide very good program logic on achieving each of the pillars of the Victorian Cancer Plan that was in process at when the outcomes framework was developed. And it provides output, short-term and longer-term outcomes. So it's a very interesting place to start or to consider when you're thinking about demonstrating the impact of the X. And the last type of assessment of impact that I wanted to consider is the Optimal Care Summits program. So as you know far better than I do, it's to cover about 20 tumour streams, and it's releasing about 3 per year is the plan. It is a very, very comprehensive evaluation based on mixed methods, inclusive of a literature review, consumer groups, consumer surveys, implemented data collection systems, as well as used existing data collection systems. An excellent, very broad approach to measuring impact. Very resource intensive to do, and thus can be done for very small areas of work in a programmed release like you're talking about, but will not look broadly at demonstrating the impact of VIX. It will be a deep dive, an excellent deep dive, but it's not at the level of measuring the impact of VIX. Okay, so in that fly pass, what have I talked about? I've talked about some of the key concepts of monitoring and evaluation, their definitions. What's that outcomes approach? Thinking about measuring impact, you're thinking about what you want to achieve and being really clear about that and focusing on that. And acknowledging what changes the VIX are accountable for. That accountability for change lens is an important lens to put over any framework or systems you put in place for demonstrating impact. We've talked about 4 frameworks. The Victorian Public Health and Wellbeing Outcomes Framework. There's some monitoring annually. It's contextual, but it's an interesting and informative light on the hill with direct lines through to hospital-based care and the VIX. The Victorian Cancer Monitoring and Evaluation Framework is reported more regularly, is much more relevant to the VIX. It has population-based hospital impacts for locality of residence and for treating hospital. And it also contains broadly contextual measures. So it includes measures for which the hospitals can control change, for which they can influence change, and contextual measures. So a broad monitoring, not evaluation, monitoring framework. The VIX monitoring and evaluation framework, though not implemented, does contain good program logic and broad evaluation strategies for demonstrating the impact of the VIX, but would need to be reviewed as it is being reviewed, I understand, by the department in some time frame. And then you have the Optimal Care Pathway Tumour Summits, which are a very comprehensive, resource-intensive impact evaluation of a specific cancer. So it's a deep dive looking at the impact of VIX, but it is not appropriate for a broad assessment of demonstrating the impact of the VIX. So if we think about what are the questions that should go through your head when you're thinking about how do we demonstrate impact of the VIX, and this is applicable also for thinking about demonstrating impact of a project. You just slice it down. Firstly, any sort of a framework you develop to demonstrate the impact of the VIX has to be evidence informed and based on best practice care. It's very clear. It has to be fit for purpose. So know your purpose. Are you looking for monitoring? Are you looking for evaluation? Are you looking for broad population reporting, even at a treating hospital level, which is a population, and then there's geography and the like? Or are you looking for patient corridors of care, pathways of care, and outcomes on a pathway of care paradigm? So consider those issues. And then when you've determined its purpose, any sort of framework has to balance comprehensiveness. You cannot measure everything. It's impossible and inappropriate to measure everything. So balance comprehensiveness, need, and the reporting burden. It has to provide actionable insights, useful information, good for decision making, has to be actionable. The measures that you include have to be beyond SMART. And we all know that the SMART is specific, measurable, assignable, as in somebody's got responsibility to do it. It's not assignable as in accountability in that acronym. Realistic, you can get change, and it's time related. We need to think beyond SMART to think about some of those issues, and it has to be aligned with the level of accountability for change. Thank you.
Thank you so much, Catherine. I feel like I've been on a very groovy E&M helicopter. I've soared up high. I've looked at all the places that I could set my landing target and where I could land, and have really thought about what it is that I want to, where I want to be, and find that light on the hill. And I think the other reflection I had was just, you know, the contextual influence and control. Also highlighted to me why we need to work with partner agencies. So, for example, agencies that do health promotion might be able to influence smoking rates, which for us are contextual, but for them they may be able to influence in some way. So our partnerships and working as a whole health and wellbeing system is so very critical.